diplomate in anti-aging and regenerative medicine with A4M, USA. She's board certified in advanced hormone therapy with IHS Belgium. And she earned her master's in nutritional medicine from Agnum, Australia in 2008. And the latest one, she is actually, she has an advanced proficiency in clinical metal toxicity and antidotes in 2020. So that is the short version of her long CV. So Dr. Kaur, you can start at any time, please.
Thank you, Dr. Sarah, for your kind introduction. Good evening, everyone, and thank you for being here for our webinar on the topic of presentation of the perfect symphony of estrogen and progesterone. So coming to hormones, what are hormones? So as we know, the hormones are a chemical substance that is produced in your body by your glands and is secreted directly into the blood. And it exerts its function on the target tissues and organs. These hormones are mainly secreted by the endocrine glands in physiological amount. Even a small amount exerts a significant change in the body. A slight excess or deficiency can result in a disease state. So we know that the hormones have the most powerful influence on your body and on how you look and you feel. So this particular slide, it depicts the endocrine glands and the hormones that they secrete. So I won't go into the details. Our focus today is on female hormones, mainly the estradiol and the progesterone. So what makes a woman is basically the two hormones, which are the estrogen and the progesterone. Now, what makes a woman, that keeps a woman calm or makes a woman very anxious and irritable, it all depends on the balance between these two. So these hormones are produced mainly by the ovaries. Once we are 25 years and above, these hormones, we start to experience a physiological decline in these hormones, and hence we start to age. This hormonal decline or imbalance, it occurs long before menopause, be it perimenopausal, or we see among teenagers this day and age that they tend to have a lot of estrogen dominance. What are the factors that influence the hormonal decline? We always start from the gut health. It's very important. So basically the diet, poor diet that is increased in processed food, and they tend to have low in nutrients. And as we know, xenoestrogen is the endocrine disruptor. It's available, in environmental condition. And these are the synthetic chemicals that tend to bind to the estrogen receptor sites. So examples of xenoestrogens are plastic, pesticides, herbicides. You tend to find a lot of it in our cosmetic products, perfumes, and air fresheners. Other causes that causes the hormone to decline is basically sedentary lifestyle, lack of exercise. A lot of us tend to have vitamin D deficiency. More than 90% of my patients, basically, they are all deficient in vitamin D. Chronic stress, a lot of usage of oral contraceptive, increasing in age, and any pre-existing chronic disease. So the ovaries, basically, they produce the estradiol, the progesterone, and the testosterone, the female reproductive system. Now coming to this slide, this is basically the hormonal cascade. So the estrogen, the testosterone, and the progesterone, all the cortisol, they are synthesized from the cholesterol. We know that the cholesterol is the building block and is the mother to all our sex hormones. So from cholesterol, it gets converted to pregnenolone. And pregnenolone can either take one of the pathways. Either it tends to break down to progesterone, which is then either converted to cortisol, or it can also go through a series of enzymatic reaction and it gets converted to testosterone. Now the other part, rather than breaking down to progesterone, pregnenolone can also get converted to DHEA. So testosterone that is later converted through the enzymatic processes to form estradiol through an enzyme known as aromatase. So this aromatization of estrogen, it occurs in the ovaries. Estrogen and progesterone, these two hormones are responsible for regulation of the menstrual cycle, development of secondary sexual characteristics, fertility and maintenance of the pregnancy, keeping the skin supple and youthful is all the aesthetic benefits of the estrogen, improving the bone and connective tissue health. So when it comes to the bone, we know that the progesterone, it tends to stimulate the osteoblast where it builds the bone, and the estrogen, it tends to inhibit the osteoclast where the bone resorption happens. Preventing cancer, protecting the heart and cardiovascular disease, enhancing cognition and memory, basically it's by the estrogen, stabilizing the mood, and so on and so forth. So let's take a look at the estradiol. Now we know that there are three types of estrogen. So let's start with the estrone, which is actually the E1. So E1 is implicated in hormone-mediated cancer. Now this is the most stimulating in breast tissue. So E1 has got three types of metabolites, mainly the 2-hydroxyestrone, 4-hydroxyestrone, and the 16-hydroxyestrone. The 2 and the 16 are the ones that causes cancer, especially the breast cancer in postmenopausal women. So E4 has got very slight estrogenic activity, and it's deemed to be the safer one. Estradiol is basically, it helps to reduce all the vasomotor symptoms in postmenopausal women, mainly the hot flushes, the irritability, the aches and the pains. And estradiol is mainly used in our compounding. Estriol is basically the ones that is the weakest among the three estrogen. It is anti-carcinogenic and its protective effect against breast or uterine cancer. So estradiol is responsible for development of female sexual characteristics. And as we know, the anterior pituitary tends to stimulate, produces the FSH and the LH, which then causes the ovaries to produce the estrogen in the bloodstream. Now the ovaries, they tend to produce the E2 and the E1, whereas the placenta, it produces more of the protective estriol during the pregnancy. So now we know that the estrogen has got lots of targets, just not the uterus, but beyond that. Its benefit goes to the brain, to the heart, the liver, and the bone. So what are the estrogens' function? So mainly to support the growth and the regeneration of female reproductive tissues, regulates the menstrual cycle, influences the growth of the breast tissue. It synchronizes with testosterone for female arousal. So now coming to female libido, it's just not the testosterone that is important. What is important is also the estrogen. It helps to maintain the healthy levels of cholesterol. It strengthens the pelvic floor. And it also exercise like the Kegels tend to strengthen it. It supports the hair, the skin, and the bone health. It influences the mood and the overall brain function, and it reduces the systemic inflammation. So the estrogen level tends to decline as we age. So coming to the symptoms and signs of estrogen deficiency. So the women tend to have the fatigue and the lethargy. Now, there are different hormones tend to have different types of fatigue and lethargy. When it comes to the sex hormones, the fatigue is throughout the day. When it comes to the thyroid hormone, any underactive thyroid or hypothyroidism, the fatigue tends to be more in the morning upon waking up. Difficult to wake up from the bed, and they tend to feel low. Whereas cortisol, the fatigue tends to be more towards the evening. There is a plummet in the energy towards the evening. Depression and anxiety. Now, estrogen acts as a natural serotonin that causes the happy hormones. And estrogen, as I mentioned just now, it tends to inhibit the osteoclast. So deficiency of that leads to osteopenic, and depending on the severity, it leads to osteoporosis. Skin laxity due to the loss of collagen, and it causes the accelerated aging of the skin, vaginal dryness, joint aches, low libido, hot flashes, and weak pelvic floor that leads to urinary incontinence. Now, this is how estrogen deficiency impacts in the vaginal health, and it's one of the causes of recurrent urinary tract infection. So decrease in estrogen leads to decrease in vaginal lactobacilli, hence decrease in the vaginal pH. Now, all these leads to increased colonization of the Enterobacteriaceae from the rectum and hence UTI. So estrogen deficiency causes high bone resorption from the osteoclast activity and hence leading to bone loss, osteopenic and osteoporosis. So what happens when there is too much of estrogen leading to estrogen dominance? Majority of the patients, they will complain of headaches, migraine, being very irritable, mood swings. Now, estrogen and thyroid, they tend to compete for the similar receptor. Hence, when you tend to have high estrogen, estrogen dominance, look out for hypothyroidism or underactive thyroid. Estrogen dominant, commonly it leads to breast cancer, endometrial cancer, and uterine cancer. It leads to fat gain, increase of weight, mainly around the abdomen, bloatedness, weight gain around the hips and the thighs. So a lot of them tend to have PMS symptoms, depression, polycystic ovarian syndrome, insomnia. That's one of the main things, because insomnia, due to when there's estrogen dominance, there's low progesterone. It leads to menorrhagia, dysmenorrhea, fibroids, so on and so forth. So this again is all what we mentioned just now, the estrogen dominance. Now, what are the causes of estrogen dominance? So xenoestrogen, as we have discussed just now, mainly it is seen in the bisphenol A that is seen in plastics, tin and can linings, phthalates that is seen in perfumes, air fresheners, cosmetic, toiletries, and plastics. So a lot of the food that tends to contain a lot of pesticides. Hence, it's always good to have some organic food. Gut dysbiosis and leaky gut, poor digestion, constipation, all these leads to slow elimination of toxins. Now, liver is an important detox organ, and when there's too much of chemicals and poor liver function, it's not being able to be excreted, and hence it gets recirculated into the body. Being overweight, fat itself tends to produce estrogen. A diet that is high in sugar and carbohydrates leads to insulin resistance. Now, when it comes to the metabolism of estrogen, it requires the vitamin B, magnesium, zinc, omega fats, and protein. So deficiencies on all these will lead to higher estrogen levels. So it's very important to control the stress, as we know that stress is the root of all evil. When there is excessive stress, there's excessive cortisol levels, and wherein there is excessive cortisol, the progesterone tends to be plummet. Now, all these leads to estrogen dominance. Now, HRT, oral contraceptive, all these pills tend to have synthetic estrogen. Hence, all this leads to excess estrogen. What are the health risks associated with estrogen dominance? As we mentioned just now, it's hormonal cancer, breast cancer, ovarian cancer, uterine cancer mainly, and endometrial cancer. So autoimmune diseases like SLE, rheumatoid arthritis, Hashimoto thyroiditis, and it leads to candida overgrowth. Now, progesterone, it counterbalances the excessive levels of the estrogen. Previously, progesterone is mainly known to prepare the uterus for pregnancy. But now we know that the functions of progesterone, it just goes beyond the uterus. As we mentioned just now, low progesterone leads to PMS, dysmenorrhea, endometriosis, infertility. So progesterone, it acts as a natural diuretic. It gets rid of all the excessive fluid due to excessive estrogen. It synergizes with estrogen to keep the bone strong. So that's where the balance between the osteoblast and the osteoclast comes in. It keeps the skin youthful. These are all the aesthetic effects due to the collagen production. Anti-inflammatory. It promotes a healthy libido and it encourages healthy nerve cell growth. So from what I know, some of the countries around the world, they use intravenous progesterone to reduce the cerebral edema in cases of any brain trauma or stroke. So that's when the function of the nerve growth comes in and it acts as a natural anti-inflammatory. So this is just briefly about how the effects, the counterbalance between the estrogen and progesterone. So when there's excessive estrogen that causes the breast stimulation, progesterone comes and it protects the breasts. Where excessive estrogen, it increases the body fat. The progesterone will burn that fat and use it for energy. Depression and headaches, progesterone acts as a natural antidepressant, natural tranquilizer due to the GABA effect, GABA aminobutyric acid, that helps to keep the patients calm. So excessive estrogen that causes salt and water retention, progesterone acts as a natural diuretic. Estrogen, as I mentioned just now, it can interfere in the thyroid function. So progesterone, it facilitates the thyroid hormone action. So now the rest of it is basically increases the risk of endometrial cancer, breast cancer. Progesterone will always protect. It prevents the endometrial and the breast cancer. What are the symptoms and signs of progesterone deficiency that patients, they normally complain of? They normally present with frequent headaches, migraines. Low basal body temperature is also due to underactive thyroid. They complain of mood changes. Most of them, they tend to feel a bit low, depressed, anxiety. Insomnia is very common. Menstrual cycle issues, where it's basically irregular menses or they tend to have spotting. During the reproductive age group, where low progesterone increases the risk of miscarriage or infertility, and it can lead to osteopenia and osteoporosis. Other symptoms and signs are basically weight gain, loss of libido, mood swings, PMS, breast tenderness, and all those fibrocystic breasts, or even having polycystic ovarian syndrome. Menopausal symptoms like hot flashes, night sweats, and vaginal dryness. So coming to the bioidentical hormonal replacement therapy treatment. So first of all, when the patients come to you with all the symptoms, we just need to take a full detailed history, right from their menarche, their age, when they had first menses. Now, this day and age, we tend to see a lot of the girls getting their menarche at the age of 9 or 10, which is way too early. Any changes of weight gain, any details of dysmenorrhea, menorrhagia, how often do they skip school, how often do they get migraines, is there any use of oral contraceptive, any gynecological issues like cysts, breast cysts, ovarian cysts, what are their dietary habits, right from breakfast to lunch, their dinner. Do they have energy levels that dips, and when? How are they sleeping? And you can even use a questionnaire and get them to fill it in. Physical examination is always important, right from the height, the weight, and then you have all the circumference, the weight, hip circumference, and the ratio. So when it comes to investigating the hormone levels, we can do a basic baseline blood test as such, full blood count, HbA1c, thyroid function, complete thyroid test, free T3, T4, TSH, ask for antibodies if there's family history of any autoimmune condition or even thyroid issues. Get the vitamin D done because 90% of the patients are deficient in vitamin D3. And now with the current pandemic, it's important. So rather than taking all the vaccination, I think we just need to boost our immune system. And vitamin D3 is one of the most natural vaccines. Cortisol, whether it's too high or it's too low, are they having any adrenal fatigue? DHEA sulfate, FSH, LH, estrogen, progesterone, free testosterone. I normally ask for free testosterone because free testosterone, it's not, we don't want the one that is bound, we want the free because that is the one that is more relevant to the clinical science and system, not the bound. So what I tend to request for, depending on their budget and depending if they're actually postmenopausal, my full profile will also include CRP, homocysteine levels, magnesium, RBC, fasting serum, insulin. So, it's good to have the very detailed profile, and you can also include the cancer markers, even though that we know the cancer markers, it is not, it's just sensitive, it may not be specific. So we need to correlate the clinical history, the findings, and the results. So we come to a diagnosis, and then you need to explain to the patient, and we come up with a treatment plan. So I normally address all my patients with the 5 pillars of health. So with the 5 pillars, we always address the gut health because it's very important what you put in your mouth. And we are not what we eat, it's actually what we absorb. So the gut health is very important. And from there, we always address the optimal vitamins, minerals, optimize your hormones, exercise. Exercise is very important because there is no shortcut. And finally, stress reduction, whether it's meditation, whether it's Tai Chi, however they want to address that. So basically before we start them on the bioidentical, we need to address all the vitamins, especially the vitamin D, correct other underlying thyroid deficiency because that's very important. Now I see a lot of patients when they tend to have the thyroid and the adrenal, they're actually related. So when they tend to have underactive thyroid, they may have symptoms of adrenal fatigue. So basically looking at the cortisol level, looking at the DHEA. So if it's high, we need to rectify. If cortisol is high, we need to address through meditation or whatever way that they need to address just stress issues or get the DHEA to balance the cortisol. And if it's low, then we just give them a low dose and short duration of hydrocortisone. So coming to the hormonal replacement. So basically there are 2 forms, which is transdermal and the oral. So coming to the progesterone, transdermal, as we know, it bypasses the liver. So oral, transdermal and oral, most of my postmenopausal patients, because they tend to have insomnia. So the oral would be better in this case because oral, when you give the progesterone, it goes to the liver, it breaks down to allopregnanolone, and patients, they tend to sleep better. And of course, it's even more economical. So that's for menopausal women, but the dosage varies. So for example, if it's a teenager, they tend to have high estrogen and all the PMS symptoms. Then depending on the levels, I would usually start at about 100 milligram given orally from day 15 to 25 of the cycle, if the cycle is very regular. So we can discuss about this later as well. So the benefits of the progesterone, you can give it in young adult, reproductive age group, pregnant mother. It's very safe if we use the natural bioidentical replacement. So postpartum is very common, postpartum blues due to the sudden drop, the plummet of the progesterone levels. So perimenopausal women, it tends to reduce the severity of the climacteric symptoms like hot flushes, irritability, mood swings. And in postmenopausal older women, it prevents cancer, it protects the brain, the hearts, the joints. So coming to estrogen, it just needs to be very judicious. And I don't mean to say that it's only estradiol is replaced. I usually combine the E2 and the E3, as we have discussed just now. The benefits of the E3, it's anti-carcinogenic, it always protects the uterus, the breast, so I would actually combine. Now, I'm actually trained by Dr. Thierry Hertog, and when it comes to estrogen, we always give transdermal. We never give estrogen via oral, because if you give via oral, it goes to the liver, it breaks down. And we discussed just now, if it breaks down to E1, which is the estrone, we don't know the metabolite. So if there's family history of cancer, we are not sure whether it's going to break down to the 2 or the 16. Those two are the one that causes cancer. So I'd rather be safe than sorry and do no harm to patients. So estrogen, for me, I always give transdermal. Now look into the personal history, the family history of any breast disease or cancer. So, so my practice is always giving transdermal. I don't give oral. However, when it comes to Dr. Neil Rosu, he practices giving oral estradiol, and so that's his way. But if I look at other bioidentical practices like Dr. Tara Scott, who's a gynecologist in the US. So she uses physiological dosages, and she uses transdermal cream. And that is the same with Pamela Smith. Okay, so estrogen, transdermal, oral. So I would always go for transdermal. Now, this slide, it depicts the difference between the bioidentical estrogen and the synthetic. So if you look at the structure, there is always an additional carbon atom, hydrogen atom that makes it different. And this is the progesterone. So when we say bioidentical, it's isomolecular. If you take the naturally occurring progesterone and you take the plant base, right? So the bioidentical, it's derived from soy and yam. And if you look at the chemical structure, it's isomolecular to that of the natural. Whereas if you look at the synthetic progesterone, it has additional carbon and hydrogen molecules bonding that attach to it. And that makes a whole lot of difference. So coming to this case study, 48-year-old, always stressed. It's a manager with a BMI of 25, as we know that's high, and the waist-hip ratio of 0.9, which is also high. Her symptoms are amenorrhea for 6 months, weight gain, bloating, loss of libido, lumpy breasts, difficulty sleeping at night, and labile moods. Now she's concerned about premature menopause and the risk of heart disease. So if you see anyone who looks like this, we all know that they really, really need progesterone. So looking at the lab tests, so if you look at a vitamin D, 38 is very low. The TSH, 3.2, it's high. We always we try to keep it less than 1.5 or 1. The T3, 2.5, 2.4, it's very low. I normally keep it at about 4.8, at least above 5. Now, T4, which is 12, this is also very low. Now, the target of it, we'll try to keep it at least like above 18. Now, estradiol, if you look into the units, so this is the picogram, and progesterone, I tend to look into the nanogram. So they use different units like nanomole, so I stick to this. So whichever one you're using, just stick to one particular. So these two are actually very low. Now, FSH and LH, this is actually elevated. It's a feedback mechanism. So the treatment plan, we always start with the diet, talk about high protein diet, low carbohydrate, regular exercise. Now, if there's a weight gain, if you want to reduce the weight, I always put them on intermittent fasting. As we know, the benefits of the intermittent fasting is just not of the weight loss, but there is also, it activates the autophagy, where there is like natural spin cleaning of all the abnormal cells, and what they call it as the destruction of the damaged cellular component. Regular exercise at least 4 times a week. Now with this patient, because of the thyroid, it's low, I would consider putting her on compounded thyroid, which is 2 grain. Either it could be the 1:4 ratio or 1:2. The 1:2, the T3 would be higher. Now, bias, I would actually combine with the E2, combine with the E3. So it'll be 0.5 of each. Now, the thyroid support, what is important is actually the selenium, the zinc, and kelp. Now, kelp is actually its natural iodine, or you could even add on potassium iodide. Vitamin D is the D levels are low. Supplement with 10,000 IU daily, and this is the recommendation for adults. And oral progesterone, 200 milligram nightly. I would, depending on the age, depending on the levels, if it's 0.2, I would probably start with actually 150. Now note that some patients, when they take progesterone of 200, they might feel very sleepy the next day, very drowsy. So if that's the case, either you can reduce it to 150, or you tell them to take earlier, like maybe about 7 o'clock after their dinner, rather than taking it at 10 o'clock. So all this will make a lot of difference. So review the patient after about 3 months. The patient's much happier. The BMI has dropped from 25 to 22. The menses started to regulate. The breast is less lumpy. Sleeping better, energy levels are better, better mood, better libido, generally happier. And so this is after 6 months. So if you look at the level, the vitamin D is already up to about 78. And I think I would rather keep it a little bit on the higher side at about 120. The TSH has come down. The T3 has improved. 5.2 is optimal. The T4 is 18. This is good. The estradiol is about 150. So this is good. And the progesterone is about 12. So what I tend to do is, if it's the age, generally I tend to keep them about 150 to about 200, around that, depending on their clinical symptoms. Progesterone usually 10 to 20, menopausal women at least 5. So FSH and LH over time, they usually tends to come down. So basically, the efficacious of the balance between the estrogen and the progesterone therapy, it empowers the patient, women generally. Now, the dietary discretion and the health food habits is a must. So always walk through them, the 5 pillars of health. Encourage exercise. There's no shortcut. Even walking in nature, grounding, all those, it helps. And address any master hormone deficit or excess, be it the cortisol, be it vitamin D3, and especially the thyroid function, or even DHEA. So always educate the patient, share with them a certain links these days, because I tend to empower my patients a lot. I educate them. I get them to read one of these books. It's called What You Must Know About Women's Hormone, and that is written by Dr. Pamela Smith, because we don't know who they're going to end up with. You know, if they go to another doctor, they may not be a believer in this integrative, in bioidentical. So it's always good to protect yourself, protect the patient, and always counterbalance any excessive estrogen with progesterone. With this, I thank you for your kind attention. Should there be any questions, I'm ready to take any questions, or if I've been a bit too fast, you want me to go back to the slides, please let me know.
Thank you, Doc. That was very nice. Thank you for your time. Any questions? That's a question for you, Doc. This is from Dr. Sangeet. For the first case you presented, you gave daily vitamin D 10,000 IU for 6 months?
I actually give them like forever. If they ask me how long do I need it, I would always tell them, look, you know, for some patients who they are not convinced that they have to take lifelong, I will always tell them that, you know what, you can actually stop after 6 months. and repeat your levels again after 3 months. So after 3 months, do your levels, and then you come back, we go through your clinical symptoms, see how you feel. And yeah, we'll take it from there. Because I've seen a lot of patients, when you take them off, the levels will actually plummet. So if you don't want to tell them that it's going to be for life, you can tell them after 6 months, give it about another 3 months, and then come back and redo your levels, and we'll take it from there.
Yeah. Yes.
Does that,
as long as
yeah.
Dr. Sangeet, that answer your question?
Yeah. Thank you.
Yeah. I think the important thing is have the patients actually engage with their treatment, so they will have more compliance, right, Doc?
Oh yes. And I think with this current pandemic, it's very important to to boost your immune system, not just with the vitamin D, the zinc, the C's, and I think that would literally be our shield to protect us from contracting any of these viruses.
Yeah. Scary. So Sangeet, another question: how to counterbalance estrogen and progesterone? I think it's actually counterbalance each other. Dr. Sangeet asked, how do you counterbalance estrogen and progesterone?
Well, I think the first thing is basically going through the clinical symptoms. Once they come and they tell you, look, I have frequent migraines, I have bad dysmenorrhea, PMS. So we already know with such the progesterone levels are low. And to convince the patient, so we do the blood test. Okay, so if a person has regular cycles, we do the estrogen and progesterone between the day 18 to day 21st of their cycle. Now, the reason being, why do we do 18 to 21st? As we know that we have, we have the follicular phase, which is day 1 to day 14, then it's the mid cycle. And then from the 15th till the 21st, it's the luteal phase. So the luteal phase is where the progesterone peaks. So if you do during the luteal phase and the progesterone is low, so we know that the rest of the cycle progesterone it's low. So now if the levels are low, we just have to correct the progesterone. And
thank you, doctor. Doctor, how do you start the dose? I mean, like the ratio between progesterone and estradiol. Like how you start and how you let's say which one how much and which one how much, and then how to look at it, whether it is like increase altogether, or I mean like the ratio. I think the ratio to start.
Okay, so which is the slide? You know what? You can use this as your reference range. So basically, now it depends on the age. So if let's say the person is in their 20s when all those symptoms, and if you look at the progesterone, and let's say the progesterone is 0.2, and let's say the estrogen, that patient's estrogen is about 150. So we know that the estrogen is fine. All right, so we don't do anything about it. But what we do is we collect the progesterone. We try to keep it at least about 10 to 20. So I would start about 100 milligrams of progesterone, oral progesterone, and then give it about 3 months. And between the day 18 to 21st, get them to do the levels again. I would say 99% of all their symptoms will actually go away, and the progesterone levels will actually go up.
Okay, thank you, doctor. So usually you do you reassess 3 months after you prescribe hormone, correct?
Yes, because I think we really need to know that, okay, that we are giving this particular dosage, 100 milligram, is actually adequate. Number one. Number two, patient is feeling so much better. So it's both, it's the lab test and it's also the clinical symptoms. And most importantly, that the patient is convinced that what they are taking is actually working for them.
Okay. Thank you, doctor.
You're most welcome. Is there any questions? Otherwise, I would like to share how to manage like menopausal women. You see, there a lot of question comes. I think the confusion is how to manage patients with regular cycle, and some of them where they are amenorrheic, they don't have any regular cycles, and for postmenopausal. So basically, if it's postmenopausal, when they have no menses at all, I would probably start them on a Monday. I tend to follow the Monday to Friday, where Monday mornings, in the morning, they apply the cream, the Bioidentical cream, and I normally combine testosterone as well, because the benefits of testosterone, it's like, you know, the benefits of the bones, it gives them the energy, it helps in the libido. So I will combine E2, E3, and testosterone, and they take the progesterone at night. If menopausal women, I usually give 150 milligram to begin with. Now they take from Mondays to Fridays, and it's always good to give the Saturdays and Sunday off, because that's how our body works. We need a hormone break. So out of 30 days, they're taking 20 days of the bioidenticals, and they're taking 10 days off, which I think it's very healthy, and it mimics the body's cycle. Now, for those who have regular cycles, then if let's say they need the progesterone, they either take from day 15 to 25, or if they tend to have a lot of PMS symptoms that starts from day 12, then it's day 12 to 25. And day 25th, they stop the progesterone. Yeah. And some practice giving from day 1, the creams, especially the Bioidentical, from day 1 to day 25, and then day 25 they actually stop for a week. You can actually do that, but that tends to give a withdrawal bleed. So some patients, they don't like the withdrawal bleed at all. So it all depends on individual, and we just need to adjust and work accordingly to their cycles and what symptoms they have and how they feel. Sorry, Sarah, Doc, I can't hear you.
Doc Sarah, your microphone
is
not turned on.
Oh, okay. Sorry. Dr. Jonsu from Singapore asked if you also consider to balance to replace the testosterone and DHEA.
Yes, if it is low, I would. Now, for most of the patients, let's say if they have already a low libido, the testosterone, it actually, you know, gives the woman a confidence, the energy, helps in the libido, better decision making, and yeah, the benefits for the bones. And if the DHEA is low, I will correct the DHEA as well. Yes.
Yep. Yeah. And another question also from Dr. John. If do you have any time limit when you're going to, how long you're going to replace the hormone?
Is there any particular age? So let's say if it's menopausal, now we need to let the patient know that, look, once they're already menopause, how they want to live the rest of their 20 years of their life or 30 years. If they are looking for, you know, they want a good quality life, then we need to protect, you know, you need all the protection of the brain, the heart, especially during the first 5 years. But I will never give them a time limit. I will just say, you can take it for 1 year, see how you feel. And if you want to stop at any point of time, please do so. You know, we can check your levels. And 99 of the patients, when they actually stop, after 2 months, they will start to text me and they say, Doc, my hot flushes have come back. I'm having aches and pains. I can't sleep. So to me, that is already a good testimony, because we are not forcing them, but they actually know. So they need to experience when they are on it and they are off it. Yeah. So I always feel you just need to always be safe and do no harm to the patient. So always use transdermal Bioidentical rather than giving oral. I mean, that would be my take.
Yeah. There's another question. Where do you get the cream?
Where do you get the cream? Well, you know, you can get Eagle Pharma to compound and
So it's actually the important thing is you don't get the cream. You ask, you prescribe the cream, and then you ask a pharmacy to compound it. And
yes.
In this case,
yes.
We use Eagle Pharmacy to compound it in Malaysia, and then you can send it well wherever we are, right?
Yeah, we can actually courier that. But the most important thing is, okay, so when it comes to prescribing, never ever give a patient transdermal Bioidentical without doing the progesterone.
Because
they always come hand in hand, and this is so important, because no matter, this is what I always say, no matter how safe you're practicing, it's natural,
Yeah.
it's bioidentical. But if you are going to give the patient only the estrogen without the progesterone, you're not doing justice to the patient. So progesterone always comes in hand, and I think quality always speaks, because like with the Eagle Pharma, we get the quality everything from Australia, so there is no heavy metals, quality is assured, and it's economical as well.
So the practice to balance the estrogen and progesterone always goes hand in hand, even when you replace it with bioidentical hormones, right?
Yes. So in my years of about 15 years of practicing bioidentical, it's like touch wood. I mean, the patients have all been fine. I've not had any who has got any, sort of cancer, and even some of them. So patient tendency is another thing. They will apply cream, but at night they forget to take the progesterone. And I've had 2 patients who had the similar thing, so I had to give them a bit of a, ear. And so because it started, so they will have bleeding. Obviously, this is like so many years of menopause. And if you tend to give the estrogen, it's going to proliferate the uterine lining. So when they went to see the gynae, did the scraping, thankfully everything is clear. There's no any, sort of like dysplasia or cancer cells. So to me, that is one of the testimony as well, that it is quite safe. But always have to reiterate to the patient, never forget taking the progesterone.
Dr. Sarah?
Yeah, there is, I think Dr. John Su again asked about the bias percentage and the testosterone percent, basically the dose.
Okay.
Right? Is that what you mean, Dr. John? The dose for the bias and testo? Yes.
Okay, so for me, it's basically, so if you're talking about menopausal, I would always start about 1.5, but there again, it depends on the level. When you do the lab test, so let's say the estradiol, it's about 20 or less than 18 picomoles, so it's like really deficient. So I will start with 1.5 milligrams of bi-East. So when we say 1.5, it's usually the E2, and by default, the E3 will be there, which is 0.5. So the E3 is always there. So if you put bias, the pharmacist will definitely compound. They put the E3 in it, 0.5 milligrams. And the testosterone, I would actually add on 5 milligram. I wouldn't go beyond 5, 2.5 to 5, and see how they feel.
And this is for women.
Oh, yes.
For women. Yeah.
This is for women. And then the progesterone at night. Look, if they want cream, you can give them cream, but I usually give them oral progesterone, 150 milligrams, and see how they go with this. Majority would respond well to this.
Another one, for PCOS, you replace.
Okay, so
what do you replace for?
Okay, so majority of the time when you do the PCOS, so first of all, they are progesterone deficient.
Yeah.
And they tend to have high androgen. So I would actually add on the conventional way is actually to add on the metformin, because they do have insulin resistance as well. So most importantly, again, we start from the diet. We have to walk through, remove all those processed food, your sugar, high carbs, and then start them on progesterone. I would also give them the metformin to reduce the insulin if the fasting serum insulin is elevated. And I do know that inositol, which is the niacin part of it, also supposedly help get them to lose weight, and just monitor them.
You also give the saw palmetto for that if you have PCOS women, or you look at the testosterone first?
Okay, I guess there's no harm in giving saw palmetto, but I think I don't usually give that, because when you do these levels, so from all those ones that I've done, when you look at the testosterone levels, it's not elevated.
Not that high, yeah.
It is because they are female, your hormones are very low, it makes them more male dominant. So we address that by giving the progesterone. Yeah.
May I ask if you use what do you use to replace the DHEA, the sulfate or the 7-keto DHEA?
Okay, so the DHA sulfate is actually the lab work, and its DHA is on its own, or 7-keto DHA. So I tend to combine. So if they want something simple, more economical, I'll just give them DHEA alone. So DHEA is for mood, memory, energy. The 7-keto DHA, it has benefits for immunity, it protects the heart, and also cancer prevention. So I actually combine. So the 7-keto DHA, you can start with 100. And the DHEA depends, again, if it's Asian woman, it depends on the level. I would probably start about 15 milligrams or 20 milligrams.
Okay. Thanks for all the answers. Very useful framework to use.
Most welcome.
Some of the tricky parts that I've come across was that when I started replacing this lady who's having hot flushes, she started with both a bias and a progesterone cream in the evening, and she started to have acne outbreaks. It's like it was uncontrollable. So I wasn't sure what I was doing wrong. Am I overshooting the progesterone, or she was having both acne outbreaks and hot flushes. Hot flushes became less with the bias, but I wasn't sure why she was having outbreaks and congestion on the face. I don't have all her data right in front of me now, because that was quite a while ago, and I didn't actually have anyone to bounce the idea off. Asking the compounding pharmacist herself, I couldn't get an answer. Do you have any thoughts?
Yeah, so I've had some patients who've got acne breakouts and all that. So I would also address, so when something like that happens, so before we talk about the hormones, we go back to the diet. I will get them to eliminate dairy products, eliminate all the sugar, the high carbs, healthy eating habits. And normally when they tend to have the acne breakouts, it tells me that the female hormones are actually low. So, so perhaps by giving, for me, when I increase the BIEs from 1 to 1.5, somehow the acne, everything disappeared. So I would fix the diet for sure, get them on zinc, vitamin C. If the D is low, correct the D as well. So now you're looking at holistic.
Okay. So when you cranked up the bias, the acne cleared up. So they were relatively having a androgen overload.
So basically, if those patients, when you take the free testosterone levels, it's never elevated. But because of the estrogen is low, progesterone is low, it makes them more male dominant, more androgen dominant, hence the acne breakout.
Have you ever come across patients who get acne breakout, ladies, when you put them on DHEA?
Yes. So patients like that, I won't start them on DHEA first. I will maybe put them on ashwagandha. If let's say they have they need adrenal support, put them on ashwagandha, put them on cordyceps, all this adrenal support. Address the female hormones first, and then only slowly with DHA. Otherwise, the acne breakout will get worse.
Okay. Very good. Thanks.
You're welcome.
Thank you. Any more before we wrap it up?
I would also like to say, if anybody needs my assistance to interpret any patient's profile, just give them my phone number. I'm more than happy to provide that support, because that's what I do. And over time,
thank you.
Yeah, so
Thank
the support
you,
is there. Yeah.
Okay, yep.
Oh, and probably
So
a
you're gonna
little
get
bit
more
of
busy.
I'm here for a reason. My service.
Thanks. Yep. Yeah, Lisa?
yes, probably a little bit announcement regarding tomorrow, Doc.
Oh yeah, okay. So before we go to that, any other question for our speaker? No. So thank you very much for your help, for your very insightful lecture.
You're most welcome. Anytime.
Yeah. So we will keep on bothering you then. Okay, Lisa, go ahead.
Yeah. Thank you. Thank you for having me.
Yeah, of
Yes.
course. Yeah. Thank you for being here. So so I will give them your number if they need it. Is that all right with you, right? You said?
Yeah, that's fine. That's fine.
Okay. All right. Okay. So you can Yep.
Dr. Kaur, don't go just yet, because we
Yeah.
want to take a picture with you, with all of you. But before that, I want to announce that tomorrow we will be having our last sessions of the Hormone webinar series at 8 a.m. Jakarta time, 9 a.m. Malaysia, and 6:30 a.m. India. Yeah. So please be prompt, because this is our last session. So can we take our photos now, Doc?
Yes.
Okay. So to all participants, please open your screen, turn on your videos, and Miss Iin.
Smile and smile.
Yes. Oh, and Dr. Kaur, could you stop the sharing?
Okay, hang on.
Okay.
Okay, yes.
Thank
All right.
you. Yes.
Okay.
Okay. Miss Iin, anytime
Yeah.
now.
Yeah.
Cheers.
Oke, bentar. Belum semua ya dibuka videonya. Ya. Cheers. Oke, sekali lagi.
Cheers. Ya, udah.
Yap.
Okay.
Ya.
Okay. Okay.
Yep.
Thank you. Thank you,
All right. Thank
doctor.
you so much. Thanks, everyone.
Thanks you. Bye. Have a good weekend.
Bye-bye, you too. Bye-bye.
Bye.
Bye-bye. So thank
See
you
you
to all.
tomorrow, guys.
See you tomorrow. Bye-bye.
Yep. Bye.